Welcome, everyone. We're so glad to have you with us. Whether you're joining us live or viewing this later as a recording, we're really glad to have you as part of this Living Well with Seizure Management webinar. My name is Naomi Hoffer, and I'm the Program Manager for the Sherry Sobrato-Brisson Brain Cancer Survivorship Program. And this webinar is part of a series of webinars. And the webinars are also part of our growing survivorship program that we're doing, where we're offering wellness classes and we're offering informational events and community activities to allow those with brain cancer to learn and support one another. So today, I'm really glad that we have a wonderful group of panelists to help us understand this topic. Our agenda is we're going to first talk about seizures and learn what they are in an overview, and then talk about interventions and some red flag warnings. Then we're going to go into the emotional impact that it might have in your life and coping strategies that you can adopt, as well as the importance of self-care and home safety. And afterwards, hopefully we'll have some time for your questions, so please submit those in the Q&A function. And at the end, we are going to stop the recording and invite you to meet us face-to-face in our After the Show Community Connection segment. So I'm going to now introduce our panelists, and I'm really delighted to have such a stellar group of panelists here to help us understand this topic. Dr. Jenny Taylor is an associate professor at UCSF and a key member of our neuro-oncology team. She specializes in caring for adult patients with primary brain tumors. In addition to her clinical care, Dr. Taylor is involved in several active areas of research, including the development and execution of novel treatment strategies and imaging techniques to improve outcomes, as well as research that focuses on improving the quality of life for patients with primary brain tumors. We also have Dr. Mary Lovely here. She is a doctorally prepared nurse, and she has held positions as a neuroscience clinical nurse specialist, research nurse, and brain tumor patient advocate. She has worked closely with brain tumor survivors and caregivers for over 30 years. Dr. Lovely co-facilitates the San Francisco Brain Tumor Support Group. She is also the patient and family navigator for the National Brain Tumor Society. Dr. Lovely is an assistant adjunct professor in the School of Nursing here at UCSF. And I am extremely appreciative to have two wonderful people here to help us understand from a more personal perspective the topic of seizures. We will hear from both Lily Stevens and Chad Findlay throughout this webinar, and we'll learn more about them as Dr. Lovely and Dr. Taylor invite them to reflect and share with us their experience. So thank you so much to all of our panelists for being here, and thank you for joining us. A reminder to please submit any questions using the Q&A function. And I'm now going to stop sharing my screen and turn it over to Dr. Taylor.
Hi. So I just wanted to first thank Naomi so much and the organizers for inviting me to talk today, and especially for Lily and Chad for giving their very important patient perspective. And just welcome everyone who is on the webinar or having a chance to listen to this at a later date. So I really appreciate your attention. So I wanted to start first with some very basic definitions. And I first wanted to just define what a seizure is. I felt like that was a reasonable place to start. So a seizure is defined as a transient occurrence of signs and or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. So epilepsy is slightly different from seizures in that epilepsy is a disease characterized by an enduring predisposition to generate these epileptic seizures, these synchronous neuronal activity abnormalities, and are caused by neurobiological, cognitive, psychological, and social consequences of this condition. So a seizure is the event, and epilepsy is the disease that involves recurrent unprovoked seizures. So the general classification of seizures and epilepsy have evolved a lot over the years. And so there's a couple of terms I know that are maybe familiar to some of you. So I wanted to provide a bit of clarification. So The first is to define a generalized seizure. So a generalized seizure is this indication of a synchronous activity that sort of spreads throughout the entire brain. And a grand mal seizure is maybe what you all were thinking is what a seizure would look like from a movie, or maybe you have a friend or a family member before your own seizure experience that you would characterize as a generalized seizure that usually involves people falling over and is tonic, clonic, sort of rhythmic movements of arms and legs. And so that would be considered a grand mal seizure or a generalized seizure. Petit mal seizures is sort of an old nomenclature that's fallen out of favor within the more recent definitions. And this is what we would often consider for children who have absence seizures, which is another term for the petit mal seizures. Again, usually true in children, and it's kind of that staring off in space that maybe you knew someone as a child who had a similar experience. So what we're mainly going to focus on today are focal or partial seizures. And these can be classified in two very distinct categories. One is complex seizures that involve loss of awareness or some impairment of consciousness, versus simple seizures in which awareness is retained. And so focal seizures are what happen with brain tumor patients because we have a specific area that is generating the seizures. There are, of course, people who do have brain tumors who have pre-existing epilepsy syndromes. However, most of the seizures that we're going to be focusing on today are associated with a primary brain tumor. So brain tumors are a pretty common cause of seizures. And seizures occur in about 50 to 80% of all brain tumor patients and is commonly a presenting symptom, which we may hear more about from our panelists today. This is seen more often in lower grade gliomas versus higher grade tumors such as glioblastomas, but can be seen in a wide range of tumors that arise within the brain, including meningiomas as well as metastatic disease from elsewhere in the body. So it's a symptom of the tumor as opposed to sort of anything, just like a headache or some weakness or changes in speech. And so similar to any other function with the tumor and symptom and sign related to the tumor it's all about real estate. It's all about the location in the brain. And so there are certain areas in the brain that are more predisposed to seizures and some areas that are less predisposed. So here on the right side, we have a picture of a brain. So some areas are not actually really associated with seizures. The brain stem and the cerebellum are not really areas of the brain that cause seizures. The most common area that can cause seizures is the temporal lobe. And this may manifest as a wide variety of different symptoms. This may seem very much like a panic attack with a flushed feeling, an actual increase in heart rate, sweaty palms, nausea. The temporal lobe on the left side of our brain, for most of us who are right-handed, may manifest as speech arrest and not being able to talk. Symptoms in the occipital lobe seizures that come from the occipital lobe, which is where the vision cortex is in our brains, may be hallucinations or kaleidoscope-like experiences. The parietal lobe and the frontal lobes are the areas that respectively involve sensation as well as motor activity within the brain. And so this is an example of what's called a homunculus. And so within both the motor cortex in the frontal lobe of the brain and the sensory cortex in the parietal lobe of the brain, each aspect of our bodies is displayed and marched out within the actual brain cortex. So the leg is involved in the middle part of the brain, and then it extends out to the arm and the hand, which is represented by a large area of the brain, as well as then down to the face and even the tongue. And so I show you this because a seizure from a tumor that's located within a particular area of the brain may actually start with abnormal movements or abnormal sensations, and then will spread throughout different parts of the brain, depending on how far the seizure may go. And so that may be why some people experience a seizure sensation or a motor activity within their face that then may spread to their hand, or vice versa from the hand down to the leg. So just to have a bit of an understanding as to why that spread occurs, I think is helpful. And seizures most hopefully are stereotyped. So seizures based on brain tumors typically recur from the same location. And so the symptoms are going to be repetitive over and over again. As far as their semiology, as far as the manifestation. So if you, for example, would not likely have a seizure in your right hand and your left foot, because those are not necessarily things that are anatomically located together in the brain. So to talk a little bit about a seizure, I think there's a analogy that I found to be helpful that I think most of us who live in Northern California or lots of parts of the West can sort of relate to. And I think it's also important to notice that most seizures last within about 2 minutes. So the majority of seizures are self-isolating and are incomplete within about a 2-minute period of time. But a seizure is kind of like a wildfire. And for any of my patients who may be on the call or watching this at some point, this is an analogy that I've been using now for several years. And I think it helps sort of describe what's happening in the brain. So the aura or the prodrome is the spark, campfire or whatever may be the instance that creates the fire. And then as that electrical property extends, as the sort of fire grows, then you end up with this seizure. And depending on how far that wildfire spreads, depends on how severe the seizure is. So a seizure may literally only be just a couple of finger twitching movements, which is a very small seizure localized in the brain, versus something that's a much more generalized broad seizure like those grand mal seizures that we talked about earlier, where you may lose consciousness and completely pass out. That's a larger wildfire that sort of briefly spread all over the brain. And then once the seizure is over, I think something that happens pretty commonly is sort of that scar that happens a little after the seizure is over, similarly to a scarred forest after a wildfire, which again I think we can all relate to. And so that may really manifest as being unable to talk very well, numbness or weakness of that affected limb, a blind spot in your vision. But over the course of a couple of minutes to hours to occasionally days, that forest will regrow. So it's a much quicker time frame, of course, than you would experience within an actual wildfire. But these are just sort of the natural history of how things can progress over time. So as that area of the brain from the seizure is sort of burns out, then there can be a loss of function, almost like a stroke, not structurally like a stroke, but may appear that way to an observer. And so, but over the course of just a few minutes up to a few days, all of that can grow back. This is a picture from Tahoe over over the 4th of July weekend. So this can all grow back and everything can sort of be back to normal in a pretty quick period of time. So I think I would like to turn to our panelists, and I'm going to stop sharing my screen here. And I would love to hear, Lily and Chad, your perspective on what it was like that first time you had a seizure, and what that experience is like for you now, knowing what you know. So I'll stop sharing my screen. And Lily, I would love to hear your thoughts.
Hey everyone, I'm so happy to be here. Thank you. That's a really good question. And honestly, when I first had my first seizure, it was very frightening for myself and my family. I had a generalized seizure, grand mal seizure. And so I don't remember any of it, but it was really difficult for my family because they didn't know what was going on. So managing the seizures and the treatment afterward it was a long time. And so over the year since my last seizure, even though I no longer am taking medication to manage them, I'm still considered having epilepsy.
Thank you. And Chad, would you also mind sharing yours? There you go. Thank you.
Sure. I guess very much like Lily, my first seizure was a generalized seizure. I had gone to the park with my daughter, who was almost 7 at the time. She was 6 at the time, and I was climbing up some playground equipment, got a little lightheaded, and that's about all I remember. Unfortunately for my daughter, it was hugely impactful because there was no one else there. My wife and other daughter were backpacking in the Sierras, and so she was kind of left to deal with me on the playground equipment, going through my seizure. But someone passing by was able to help out and call 911 and stuff. So I think that it probably lasted somewhere between 2 to 5 minutes before my second seizure. It was about 6 days later with my wife. And again, that was another tonic-clonic full lights out. But I actually felt it coming on at the time, so I could kind of sense it at the time. And I remember trying to tell my wife, hey, it's happening. But she told me later, actually, I was saying nothing. I just knelt down on the ground and went into the seizure. So that's the actual experience of my first 2 seizures.
Thank you both. That was very helpful. And I think it highlights an important point, which is that these focal seizures, even though they can start from the original area of the tumor, they can spread very quickly. And that's one of the things that are very worrisome about seizures as we go through and we talk a little bit more about treatment. The goal, often it's helpful to have the opportunity to try to sort of rescue a seizure. And I'm sure we might hear a little bit more about that from the panelists going forward. But seizure medication is intended to do that. And we'll talk about that in the next couple of slides. But yes, these seizures can be, I'm a neurologist. I've seen several seizures over my career, and they are still it's a very stressful thing to witness. And from any loved one or a family member, but in particular, I can certainly recognize that to be true from a child. And they can cause physical injury as well. So a large seizure, with this tonic-clonic activity of all of the muscles, they can cause significant, if with a fall, of course, if you're falling off any sort of elevation, there can be dislocations of shoulders. I've had a few times with patients from seizures. I've had patients who've gone into atrial fibrillation or irregular heart rates from their seizures. So even though we certainly do a very good job of controlling these seizures, this is one of the reasons why is because we're trying to minimize physical injury. And when someone has a seizure, there is often the muscles that are involved in breathing are muscles that are contracting with the generalized seizure. And so we worry about aspiration or something going down the wrong way into the lungs, which can set up something like a pneumonia, which can be of concern as well. And then when they don't stop, or if they cluster together frequently, they can lead to difficulty with breathing. Similarly with the aspiration, if you can't you can't control which way your saliva or something is going, then that can also create, those are similar muscles that help you affect your breathing. And so sometimes people need to be put on ventilators or assisted with their breathing in case a seizure doesn't stop on its own. This is not something where you will swallow your tongue. I think that's a common myth associated with seizures. And I know Mary's going to give us some information about first aid, but don't worry about having anybody swallow their tongue. And seizures are more concerning when they last longer than 2 minutes. As I stated before, most seizures end within 2 minutes. And so the longer it goes on, the longer it's likely to go on. So we want to be sure that we're trying to use treatments to keep them shorter. And then they're often, if they're repetitive, and this is certainly true with children, then there can be difficulty with cognition and also common comorbidities with mood alterations that we'll talk about a little bit more in the future. And then of course, it's a very stressful experience, and the anxiety of having another one of these episodes has been alluded to by our panelists. So we need to treat these seizures, even though they may not be very common, they can cause significant injury. And so AEDs are anti-epileptic drugs. And in order to have a therapeutic benefit, they need to be daily medications that are constant level in the bloodstream. You can sort of think about it like high blood pressure medication that need to be in the bloodstream at a frequency that decreases the risk of seizures. That may be once a day, that may be 3 times a day. Most often I would say it's 2 times a day. So these are daily medications to decrease risk. versus rescue medications, which we will also talk about, that can be taken if there is enough time for a warning to help abort the seizure. So these are mutually exclusive treatments, and we'll get into that in a little bit more detail. And then rarely there are instances where surgery itself can be a treatment for seizures, aside from brain tumor patients presenting with seizures. If brain tumor patients have continued difficulty with seizures, occasionally it may be reasonable to go back in and do an additional surgery. Or people who don't have brain tumors but have seizures, there may be instances where surgery is beneficial. So that's something I know that your neuro-oncologist is always thinking about as well, if the seizures become difficult to control. And so, so this is a group of firefighters, to continue with our wildfire analogy. And what they're doing, they're not fighting a fire actively, they're doing maintenance. They're working in the off season to clear brush and to try to keep things like this house protected from fire. And again, that's what your seizure medication is intended to do, is it's sort of doing the day-by-day work in the off season to keep that fire risk low. And so that is often true even for patients who've never had a seizure. So for many brain tumor patients, within the first 1 to 3 months after their surgery, even if seizure was never part of their journey to identify the tumor, they're often on anti-seizure medicine as extra layer of protection after the surgery. And if there's no history of seizures and it's felt to be okay to decrease or stop that medication, then that will be discussed with you and your neuro-oncologist. However, even several patients who present with seizures and have their tumor fully resected may still need to have seizure medications or AEDs after their surgery. And again, it's the intent of these firefighters sort of being there at the ready in case some of the red flags, which we'll discuss later, sort of increase that risk or lower that seizure threshold. And again, this is a discussion very much to have with your neuro-oncologist or your neurologist. These anti-seizure medications do need to be daily. So these are not things that can just be taken, if you're not feeling very well. In order to be protective, they need to be there all the time. There can be a need to start at a low dose of the seizure medication, and we'll talk about that in the next few slides, but it can take some time to minimize side effects, to titrate up on these seizure medications. And so to find the right combination of the right dose of the right medication, it can take a little bit of time. And I know that can be very frustrating if there's breakthrough seizures during that time, but the hope is that usually this is a pretty, we usually can get pretty good seizure control. Some seizure medicines need to be monitored of their levels. Several seizure medications do not. And so again, that's something to discuss with your neurologist or your neuro-oncologist to see if there's blood work that you might need in monitoring these seizure medications. So here we have our wildfire, sort of campfire, pretty low, but it's definitely a seizure risk. And this would be an analogous to having the brain tumor, even if it was fully resected and well controlled after surgery. And here we have a firefighter who is sort of representative of an anti-epileptic medication. And so the goal here is to balance how often these seizures may happen or how bothersome and risky these seizures are, with making sure that the side effects of these anti-epileptic medications are well balanced. And that is a teeter-totter, and that can be very challenging over time. And there are several side effects that are common to anti-epileptic medications. These are by no means the total list, but these are common things. And so we're trying to discuss, if a seizure isn't very often, or if it's just, a numbness in the hands that occurs every couple of days or weeks, but the seizure medication may make someone feel very tired or groggy or cause a rash, then those are balances that you'll need to work with your doctor to try to optimize. So some common systemic side effects are rash. Some seizure medications can cause a very, very severe rash, again, which is why they need to be started at a low dose. Some can cause nausea when you first start them. One of the main risks of long-term use of certain anti-epileptic medications is bone loss or osteoporosis. And so vitamin D and calcium are often recommended as supplements for long-term use of anti-epileptic medications. Some more common neurologic symptoms are usually associated with starting the new medicine or increasing the dose, and often will get better over a little bit of time. But these include dizziness, drowsiness. A lot of seizure medications can cause changes in mood. They may exacerbate anxiety or depression or cause irritability. And so these definitely need to be discussed with your doctors. And then because these are medications that are acting to suppress the potential from the source of the seizure, these are all things that are common side effects from something that's acting on your brain. And so the seizure is in the brain. It's most likely from the tumor. And so in order to use medications to minimize the risk of those seizures, there is often neurologic side effects as well. And again, trying to find that balance can be a real challenge. So I pulled this list out from UpToDate, which is a physician or healthcare utilized sort of encyclopedia. And this is from this week. And so this is a very large list of multiple different anti-seizure medications. The second column here are systemic side effects: nausea, vomiting, rash, fatigue, etc. And then potential neurologic side effects. Now, the frequency of these are not necessarily delineated within each in particular subtype and seizure medication. I'm not going to go through them all in detail, but I think that the intent to convey here is that there are a lot of different options. And so trying to strike that balance is certainly reasonable. And I think your neuro-oncologist is hopeful to be able to achieve that, but it can take some time. And for some people who have reasonably easy to control seizures, you might just need one medication at a fairly low dose. However, there are certain seizures in certain locations of the brain or certain inherent biology features of the tumor that we don't necessarily understand that may require multiple different sort of frontline treatments to try to minimize the risk of spread, to try to keep the seizure shut down as soon as the spark potentially flies out. So you're trying to minimize that transition from the sort of campfire to a spark getting out that may create a wildfire. And so you need to have these guys and girls there at the front lines all the time. And so you might need one or you might need more than one. And then there might be instances when a seizure may be happening that you sort of need a different approach. And having enough firefighters there, there at the ready may not necessarily be the best choice, and adding more firefighters may not necessarily be helpful. And so this is where rescue medications, lorazepam, alprazolam, diazepam, midazolam, these are benzodiazepines that can help shut down the seizure when it's happening. And so if you're on a sort of daily anti-seizure medication, that may allow the less of a spread or a less quick spread of the seizure, and may provide a window of opportunity to use one of these medications to try to shut that seizure down. These rescue medications, as I discussed before, are not interchangeable with the daily seizure medication. So taking more daily seizure medication to rescue a seizure when it's happening is not going to be helpful. And similarly, taking a rescue medication on a daily basis is not going to work for very long to prevent a seizure. So both of these are tools in your arsenal that you can have to help minimize the risk of seizure. And speaking of minimizing risk, so these are red flag warnings, which is, again, something I think we're all very familiar with. And Mary Lovely is going to discuss this in a little bit more detail. But just like when there's fire, weather, which we're getting into in the next couple of months, high winds, low humidity, all those things are risks that we all need to be on the lookout for. And so the most common red flag warning for patients to increase the risk of seizure or lower their seizure threshold is not getting enough sleep. So insomnia, you know, a new baby at home or a puppy at home, or, you know, being worried about things. These are all things that can create disruption in sleep, and sleep is critical to help minimize the risk of seizures. The second most common reason why there may be a breakthrough seizure is missing medication. And so, as I mentioned, some of these medicines might need to be given once a day or 3 times a day, but taking them on schedule, keeping that level constant, is really critical. Illnesses, and specifically fevers, can increase the risk of seizure or lower the seizure threshold. Heavy alcohol use, not necessarily daily alcohol use, but heavy alcohol use, as well as certain recreational and prescription drugs. There are certain antidepressants, for example, that are associated with lowering the seizure threshold. And so again, this needs to be discussed with your doctor, as well as some poor dietary habits and hydration. So Mary Lovely will discuss kind of the ways to help minimize these risks. And then when I was looking this up, it brought up psychological stress. And I think this is a really, really hard thing to understand from a biologic perspective. And it's really difficult for us to avoid completely. But in my career, I've certainly had a lot of patients say, well, I feel like the seizure came on because of stress. And so I don't quite understand the biology of that or how to mitigate that, but having that awareness, I think, is helpful. What you don't see on this list, which I think is also important, is tumor progression. So a seizure is not always associated with tumor growth. And everyone is worried about that being true when it happens, but these red flag warnings can create seizures even in an instance where the tumor is very stable. And so I think that that's important information also to keep in mind. And with that, I will stop sharing my screen and let Mary Lovely take it from here.
All good. Well, it's nice to be here and to talk to you about the impact of having seizures. I thank Dr. Taylor for doing such a fine job for telling us about seizures and about the physiology, a little bit of physiology, but mostly about the triggers and about how it affects your brain. It's so nice to know that. And I know people who I've worked with for over the years so appreciate understanding more about their seizures. So I'm going to talk a little bit about seizures, and there's having seizures is an emotional impact. There's a physical and cognitive impact, a social impact, and then we've got some practical impact of daily life. So looking at the emotional impact of seizures, people can feel overwhelmed, and survivors and caregivers have told me this over the years, and I think I might be speaking to the choir here today as well. You can feel overwhelmed, frightened, worried, angry, and more. Seizures really can disrupt someone's life, and you have to learn how to live with them. Also, one of the main issues about seizures is the unpredictability. When is this seizure going to happen? And it is very difficult when when someone has a seizure in public. The reaction that people have when someone has a seizure in public is everybody looks down at the person having the seizure, like, what's going on? So after you've had the seizure and you look, you go, oh my God, what's happened? So it's a really tough time. I think that also we think of feeling of losing control of your body, which none of us like to do, and that can happen when you have a seizure. And this all leads to a sense of insecurity. And we also think one thing a seizure can happen to us, and it really has an emotional impact on us, is independence. We can lose our ability to drive, sometimes taking care of the kids, or taking care of loved ones, or just being part of something because of the fear of a seizure. And also living independently. That may not be something you can do. Now, not everybody reacts the same having a seizure, and the people react differently, but in every respect, there is a huge psychological impact. that causes frustration by the seizures. And this cannot be underestimated, that of the psychological impact of having seizures. I think there's also another part of this is that there is a stigma to having seizures, and when some people hear about someone having a seizure, they get worried, and that it becomes internalized. So there is a psychological impact to both the caregiver and the survivor. And finally, it may cause people to be more prone to mood changes. And we know in studies that people can have depression and anxiety. Now, this depression and anxiety may be brought on a little bit by the medications and also by the tumor, the treatment, and everything. So they are more prone to mood changes. Now, the physical and cognitive impact, as Dr. Taylor was saying, it may affect sleep. People may feel tired and unrefreshed. And we know that sleep is a very, very important part of managing seizures. But that is one of the areas that both the seizures and the treatment may affect is sleep. Another part is it may decrease the amount of exercise done. There's been studies showing that people who have seizures have do less exercise than people who do not have seizures. And finally, it may bring on fatigue. And when I define fatigue is an overwhelming tiredness that cannot be resolved by sleep. And this is where you're just exhausted and you just can't move one more step. So we have to worry about that. And on the cognitive end, we know that seizures can affect memory, usually short-term memory, and attention, the ability to attend to an activity. These are cognitive issues that many people can attest to. Now, the social impact. The social impact of having seizures, first is social isolation. Fear of having seizures in public may bring on social isolation. So people will stay at home more and not be as willing to go out. And the other one is a difficulty in maintaining social relationships. Some people don't understand seizures, and it's hard for people to relate to people who have seizures. So this can be very difficult. And then there's the other area that we need to talk about and think about is the work environment and the group environment. And work environment is very tricky when having seizures because some people really understand them and they will be there for you, and other people have no idea how to manage a seizure. So this really can have a social impact. So let's talk about some solutions for managing emotional, social, physical, and cognitive changes. And first of all, I just want to recognize that it is not uncommon for people to feel insecure about having seizures. So talk to your doctor or your safe friends about what it is like to have seizures. When I talk about safe friends, I'm thinking about people who understand, people who know that if you have a seizure, it's going to be okay. And it's nice to have some safe friends. And sometimes it's family, and these people will help you feel better about these seizures. Attend a brain tumor support group where seizures are commonly discussed. I am one of the co-facilitators of the San Francisco Brain Tumor Support Group, and many times we talk about seizures, it comes up, and then people around the room will talk about having a seizure, and they'll say, well, I had a seizure at work, or I had a seizure in bed, or this. So, and then it demystifies it, and they know that other people have seizures just like they do. So it's very nice because you're not alone. And that's such a big feeling, as to know that you're not the only one having seizures, and people are doing fine living with their seizures. and to continue to lead an active life. This is not going to stop you from living. There's, even though there are some issues that need to be dealt with, and they can be dealt with, and going to the neurologist and going to the neuro-oncologist and having good family discussions really helps. Now, also, be aware of the symptoms related to seizures and medication. And Dr. Taylor had a very good discussion on this, but it's good to like we say, be aware. Talk to your doctor about feeling fatigued or hazy. Many medications make you feel hazy, and with a little bit of a change in medication, or find out, well, maybe I've been on medication for 3 or 4 months after surgery. I haven't had seizures. Maybe it's time to have a talk with your doctor about staying on medications or changing to a medication that does not cause that feeling of fatigue. If you're feeling anxious or depressed, that is very important to have a discussion about this, because it can really set you back as far as being able to do your activities and having a full life. So this is another good discussion with your doctor or with your nurse, and you can get some help. And then it's the other area of a solution is to take care of yourself. All the things we were talking about, develop a daily routine. Get up in the morning, go do something, and move on through the day, and then go to sleep at night at the same time. When you have a good routine developed, you sleep better. And you remember to take your medications more. It just helps you throughout the whole day. Sleep 7 to 9 hours a night. Sleep is so important to managing seizures. So I just wanted to hope that you can get that amount of sleep. It seems like a lot, but it will make a difference. Eat a nutritious diet. People who have these have diets that are high in sugar or not balanced, they don't feel good, and it can be a problem. So I strongly recommend eating well, eating 3 meals a day, and watching what you eat. Another one is to have a regular exercise regimen. This will be really important because it increases your blood flow around your body, to your heart, to your brain. It also helps you sleep better after exercise. And we know that sleep is the best remedy for fatigue. Also, if sleep decreases stress, and stress can, as people have told me as well, stress can bring on seizures. So if you exercise and you sleep well, you have less stress. So this is the time for when Dr. Taylor is going to talk about driving.
So I just wanted to comment a little bit. I know one of the really challenging and sort of shocking things about what happens after a seizure is being told that you can't drive. And I know that, as Mary alluded to, that's a very, very challenging logistical, really hard thing to figure out with your family. You may be needing more medical appointments, et cetera, et cetera. So this is from the California DMV website. And what they define as seizure is one of these lapse of consciousness episodes. And says, so the definition here is regardless of what causes a lapse of consciousness disorder, it can affect one's ability to operate a vehicle or vessel. If you lose consciousness for a short period of time, you can also lose control of your vehicle, which can result in serious accidents or death, not only, of course, for yourself, but potentially for someone else. And so these laws about driving, it's really important to understand, are state specific. I've lived in 4 states, and California is the only state I've lived in where it is my duty and legal responsibility to report a lapse of consciousness episode. So even if it was passed out or not quite sure it was a seizure because it might have been unwitnessed, these are still lapse of consciousness episodes. If you have an impairment in your consciousness, then until we get those under control, it's not safe to drive. And so what we have to do as physicians is report these episodes to the Department of Public Health, and then the Department of Public Health in turn will contact the DMV, and the DMV will send you, as the patient, additional information. Thank you. So I think it is also important to understand that whether, when, and how you get your driver's license back, which most likely you will, is really up to the DMV. And so we as the physicians provide testimony to what we think that risk is, but these are the things that I took off of the website that they include, that the DMV uses to factor in gaining your driver's license back. So effect of the disorder on the physical and mental abilities which are necessary to safely operate a vehicle, individual's testimony regarding his disorder and ability to drive, testimony of other individuals of the same, whether or not the seizure is under control with or without medication, individual's compliance with the prescribed medical regimen, other medical conditions, the individual's driving record. So that's not something as your doctor that I'm going to have any information about. So again, that's part of the factor that the DMV considers. Other relevant factors which may affect the individual's ability to drive, and a current medical evaluation conducted by a physician. And so I think it's important to understand you can be on anti-seizure medicine and still get your driver's license back. So this is an example of what the DMV, maybe this is a refresher for many on who are watching this, but this is what the DMV sends you. It's 5 pages, and the first page is mainly information about you. And this can be found, it's a PDF that's readily available. You just Google it, but this is from the DMV from California. And then on the right is essentially what the part of this 5-page document that your neurologist or that your doctor will need to fill out, and it attests to this lapse of consciousness disorder, which we have previously defined. And so it says, when did this last happen? How often is this happening? For how long have these been happening? Are you compliant with your medications? Are there drug levels that need to be followed? So all of these are parts of this form that your doctor will fill out and then send directly to the DMV. And usually what happens when something like this occurs, when a lapse of consciousness episode occurs, that someone's put on medical probation. And there's a couple of different types of medical probation, but the one I'm most familiar with for sure is type 2, which means that it's defined there. That is for drivers who have achieved 3 to 5 months of control. The driver is required to authorize their treating physician to complete the driver medical evaluation. That's the 2 pictures that we have just looked at, and submit it to the DMV on a prescribed basis. So this hasn't happened to me frequently or anytime off the top of my head. I usually do this once, and then the coordination is between you and the DMV about how to get your driver's license back. And again, the decision to place a driver on medical probation should be based on combination of considerations: seizure type, manifestations, medical and lifestyle history, and the seizure-free period, which is, I think, the most important component of things. And so for medical probation type 3, patients can resume driving after at least 3 months of control. Again, this can be discussed with your doctor. Sometimes it's up to 6 months. There is also a medical probation type 3 for patients who need at least 6 months of control and are at risk for another seizure for whatever particular reason and require regular reporting to the DMV. And unfortunately, my understanding is that patients who have had a seizure or have a history of epilepsy aren't able to hold a commercial driver's license, so to be a licensed truck driver and drive across state lines. And so I think that can be a very frustrating thing, as Mary was alluding to, as it relates to work. So again, 3 months to 6 months, depending on the discussion with your doctor. But the vast majority of people are able to get their driver's license back, even if they're on anti-seizure medication. And so I think with Mary's comments about sort of the emotional, practical, social impacts of having a seizure, I'd like to turn it back over to our panelists for their perspective on how this has impacted your life and what's been most difficult and what are some of the challenges that you've been able to overcome. So maybe I'll start with Chad first this time.
Yeah, so in terms of impacts to my life, I was thinking about this as Mary was talking. I'd have to say that the most significant impact has been the side effects, managing the side effects for me. And early on, it was kind of difficult for me to differentiate side effects from the medicine, of which I knew nothing about. And they increased the dose as I continued to have more focal seizures. But it's hard to differentiate those side effects from the actual, I guess, tumor growth. And there was, I believe, some extra inflammation after the seizures that impacted my abilities to walk, think, emotional difficulties, and then throw in a couple craniotomies in there. And then, but I think today, I was discussing this with my wife recently, I think managing the side effects has been most difficult. And ironically, Dr. Taylor was mentioning the, common side effect of drowsiness and stuff. And the one that I'm on actually I have difficulty with sleep. So I'm not able to sleep more than 6 hours at a time. Typically I sleep 4.5 hours at a time before waking up. Now I've got a lot of techniques to go back to sleep. That's kind of ironic, right? Because, we want to sleep more, but I'm taking a medicine that actually makes my sleep more difficult. So I have to make sure I get lots of naps in the day. On one hand, I'm trying to keep rested to avoid all sorts of the health implications, negative health impacts. But the medicine doesn't necessarily always want me to do that. So, and I think some mood changes too. The side effects have been huge. The second most significant impact I think that the seizures themselves had on my life is fear of reoccurrence. And I was thinking about this earlier when you were listing some things, Mary, on your slides. It's not so much that I have a personal fear in my situation of it happening. It's more the impact that it will have on my family. It took a few months for me to really understand what my wife went through and to realize that she was traumatized by it. It lasted for a significant amount of time, in excess of 3, maybe going on 5 minutes. My skin turned colors. I wasn't breathing, foaming at the mouth, the whole thing that we can all discuss. But I think my fear of recurrence is probably one of the bigger impacts on my life that seizures have had, not for me, but for my loved ones. So the driving was certainly tough. I like to liken it to balance. I wanted independence, so I was seeking my license back within 6 months, and I did get it back. On one hand, I'm independent, but on the other hand, when I think about fear of recurrence and the safety of my family when I'm driving, that's kind of a tricky balance there. So I think that's my answer to the question of how it's impacted my life.
Yeah, I can totally relate to what Chad was just saying, and then also what you said, Dr. Taylor and Dr. Lovely, about all those things that were affected by having seizures. I think mostly like what Chad was just mentioning, the emotional and then the physical impact that seizures can have on one's life. I can completely relate to that. Like, I think the emotional part of it, the side effects of the medication and the seizures themselves, I dealt with new anxiety and agitation and irritability, which was something that I hadn't really dealt with before. And that was really challenging because that affected social and like how to interact and my family. It was just a stress for all of us. The physical part of it, I really noticed a change in my thinking, and I had fatigue. Sleeping more became, like they mentioned, it really helped to kind of cope with it. It kind of felt like there were just roadblocks, like my brain was kind of shut down with to a maybe more extent. And so just living my daily life, I was going to school at the time and not being able to drive and managing everything was really difficult. I remember after my second surgery and then seizure, and I wasn't able to drive for the second time. I had gone through the whole process of getting it back with the DMV, which was really a big job. And then I was at the emergency and he was like, "You can't drive." I just remember just crying because it just is, there's a lot of things to manage. So yeah, that. I think those two things, the emotional and then like the lack of independence, were the hardest things for me.
Thank you so much. That was very, very helpful. Um, shall we continue to move on with our presentation? I'm going to share my screen again. So now we're going to talk about some practical solutions. And this is about taking your medications daily as prescribed. As we know, that one of the main reasons why people have seizures is because they don't take their medications on a regular basis. They forget or something. So here are some tips on how to take your medications daily as prescribed. First of all, do not skip a dose, and do not stop taking your medications without your doctor's approval. Many of these medications require that if you're going to go off of them, you need to be weaned. And sometimes you go off one medication and then you go on another medication. And it just takes a little bit of time to make that change. So please talk to your doctor if you're going to be, instead of just stopping a medication. Use a pill organizer and fill it ahead of time each week. Pill organizers are great. You have 7 days worth of pills, and you can just go through Monday through Sunday. Many people will do it Sunday, and then every day that week they're taken care of. Pill organizers are great. I use them myself. Set an alarm to remind yourself to take medications. And if you have one of the great watch alarms now, or something that just says, okay, time to take it, it'll be much easier to remember. Another one is, if you are unable to pay for your medications, talk to your doctor or talk to your nurse or social worker, because these very helpful healthcare professionals may be able to find some payment options for you, or grants that are available through the drug companies. I know medications can be expensive, and it's a true challenge. But seizure medication is so important. There are some options. If you have been vomiting, let your doctor know, because it could decrease your absorption of your medication. And you want to make sure that you're getting the amount of anti-seizure medication that you need. And another important issue is to keep your refills up to date, and keep at least 7 days of extra pills, especially if you're traveling. So go in and make sure you have enough of extra pills. One option is to have the 2 pill organizers filled at the same time, so you always have a backup of extra 7 days worth of pills. Remember the medication side effects. You can have some dizziness, feeling hazy, fatigue. Sometimes you can have some memory issues. And then Dr. Taylor gave us a nice description of other side effects. But the doctor may be able to change your dose or change your medication. And it's worth having a discussion about anti-seizure medications with your doctor. Here's some home safety issues. Home safety is really important, because seizures can cause issues and problems, and you want to live a full life, but you have to think about some safety issues, because if you do lose control of your body, are you going to be okay? So first of all, I think of water, and water can be an issue. So if instead of taking a bath, take a shower and keep the bathroom door unlocked, so someone can help you if they hear anything. Another one, swimming and hot tubbing should be accompanied by, if you are swimming and hot tubbing, you should be accompanied by another person. In case anything happens, because there have been some drownings associated with people having seizures. So this is this is something that I've seen in my practice. If you have seizures at night, and night seizures are not that uncommon, consider having a pillow alarm. So pillow alarms can alert somebody that a seizure is happening. Seizures are also an issue for household clutter, because if you're trying to get around or someone has a seizure on the floor, they can hit their head, or they can bang into the side of something or fall over an empty box. So get rid of the household clutter to prevent injury. Also, one thing that a lot of people do who have had seizures is they have a medic alert bracelet, or they have some jewelry. It could be a necklace or a bracelet that tells them that they have a seizure issue. And consider a medic alert bracelet. And if you live alone, consider a medic alert system in your house. So now I'm going to talk about first aid, or what to do if a seizure occurs. So I've separated the seizures out. I will talk about the focal seizures first, and then I'll talk about the generalized seizures, like tonic-clonic grand mal seizures. So with a focal seizure can be as simple as twitch of a face, movement of an arm. It can be a very simple activity. There's something that is not controlled. But you can also have a focal seizure where somebody can be in kind of a deja vu, hazy state, where they're halfway conscious, halfway with it. So what I usually do and tell people to do is first just observe the focal seizure and see and watch it before you go diving into anything. Just watch and see how the person is doing. If the person is in a dangerous situation, slowly guide that person from danger or from something. Because if they went into a generalized seizure, again, you don't want them to hit anything. So you observe, you guide the person from danger, and you stay calm the whole time. It is so important for people who are going through a seizure to hear a calm voice, and that's what they've told me. Be reassuringly calm. If you can time the seizure, it would be helpful. And stay with them until recovery is complete. As we said, most seizures last for about 2 minutes, not longer than that. But sometimes it's just nice, because sometimes it doesn't change their consciousness at all, and other times they just need to know what's been going on. And you explain to them anything they've missed or forgotten, if that's what they'd like. What are the things not to do during a focal seizure is do not restrain somebody. Do not act in a way to frighten them, or assume they know what's happening. Even though it might appear that they know, they do not assume they know what's happening. Do not give them something to eat, and do not try to bring them around. So stay calm. Stay calm with them, watch them, observe them, and keep them from danger. Now, for a generalized seizure, commonly people with generalized seizures become unconscious and they fall to the ground. And this is very scary for people around them. So first of all, you move anything around them that could be of harm. The first thing you do is make the area safe. So you remove anything around them. That's the first thing. You protect them from injury by moving harmful objects. And then you cushion their head so they don't, if their head is moving up and down, so they don't bang their head. And you stay with them, and you just stay calm again, and you're quiet. You be calmly reassuring. You just are there, and you say, I'm here, even though they're probably unconscious, or they may not be, but just be calm, and that helps. Time the seizure, and when the movement starts slowing down, just over to the recovery position that's in this slide, because this helps them with breathing and removing of the secretions in their mouth once the seizure is finished. And you just stay with the person. Sometimes I'll just lay my hand on their shoulder, and that feels very good just to know that someone's there, and I will tell them that someone's there. And if they're onlookers, I will commonly say, it's okay, we have this situation under control. And then stay with the person until the recovery is complete. Now, and like I say, and as Dr. Taylor said, there's usually only one seizure. And then if nobody knows this person, then you call 911. If this person, you don't understand what's going on. Just to tell you that most people after a generalized seizure, they are exhausted. They, as Dr. Taylor said, they might have a weakness in a leg. They might have some speech problems. So don't be surprised if the person just lays there for a while because they're exhausted. So do not restrain their movements unless they're in danger. Do not put anything in their mouths, and do not try to bring them around. They will come around. Now, when is a seizure an emergency? First of all, you call 911 if it is the first seizure of either type and nobody knows anything about this. It's the first seizure, you call 911. You call 911 if a generalized seizure lasts more than 5 minutes or there's 3 seizures in a row. This can cause a lot of oxygen use in the brain, and you want to stop the seizures as soon as possible. Also, with focal seizures, if they repeat themselves and then they become generalized seizures, that's another reason you call 911. And finally, if a person becomes injured by just hitting something or breaking their arm or whatever, just by falling in the wrong position. So that's really important. Now we're going to ask Lily and Chad to tell us about how they cope with their seizures. Lily?
Okay. I can again relate to a lot of the things that you just mentioned. And I really wish that I had a webinar like this. It's had a lot of resources that have been really useful and for me and my family. So I think that like understanding and awareness and self-compassion, and it's kind of like a stepping stone to learning how to, on the road to kind of coping with dealing with this. And like you mentioned, a daily routine. To be able to take medications and remember to take them, having those pills, all those things were really, really helpful to me. I think also what was also incredibly useful was after my second seizure, I met with an epileptologist at UCSF, and she helped navigate and help me get through the whole process and how to manage it as time went on.
Chad?
Yeah, I echo what Lily said about the routine, especially for the medication. For me, that was a struggle originally, partly because I was just so absent-minded and forgetful. And then after that, my watch alarm would go off, and then I'd say, oh, I better go take my pill, and then I would forget. So that's probably one of the biggest resources or strategies. For all the side effects that the medicine has caused me, the benefits far outweigh it for me, for the reasons I mentioned earlier, just because I feel, I guess, knock on wood, confident that they're preventing them from happening again. And that's not something I want to go through, because it caused a lot of side effects afterwards, just having had the seizure, not to mention the impacts on my family. Some resources and strategies also, I think, for me are to avoid triggers, or what I believe to be triggers, that I think some of which have been presented today in this slideshow. and that's caffeine. In both cases, I've kind of had to piece together what I was doing prior to the seizure happening. And in both cases, I'm not proud to admit this, but I was kind of a caffeine junkie. I would work long hours and drink a lot of energy drinks, and both times I had energy drinks and or a lot of coffee. And I think that in of itself can, in large enough doses, trigger a seizure. So I stay away from the caffeine and try to make sure I get the sleep throughout the day that I need. So those are the key resources and strategies that I use now.
That's very, very helpful. It's so nice to hear from you, both of you. So we'll go back to this. So we're almost winding up here. And I just want to say that self-compassion, just as Lily was saying, self-compassion and understanding is so important. Self-compassion means, I'm not alone, and be kind to yourself. This is something, many people live with chronic illnesses, and you're not alone. You don't have to be. And if you're kind to yourself, it's just, it's okay. We can make it through this. And to understand your experience, which I find fascinating, an interesting concept, because you do kind of have to empower yourself to know, how am I going to live with this? What are my triggers? How can I change this so it's not going to happen? What can I do to not make this happen? Track it, analyze it, and report it back. Awareness, assessment, that's what it is. We need to find it out and then figure it out. So that's what it takes. I just want to finish by saying, in most cases, seizures from brain tumors can be controlled, and people with seizures do live a full and independent life. We've provided you some resources today from the Epilepsy Foundation, which is an excellent resource for patients and caregivers. Very Well Health. The Brain Tumor Charity has a wonderful section for survivors and caregivers, especially for brain tumors, and then all the California DMV information. So that's the end of our presentation, and I want to thank you.
Thank you, Mary.
Yeah.
Thank you, Mary, Dr. Taylor, Chad, and Lily. Thank you so much for sharing this wonderful information. It's about the time now that we start the After the Show, but before we do that, I just want to leave with a couple of reminders. One is that we are going to be sending you an email for all of you that registered via email and through our site. We're going to send you a follow-up email with a link to this recording, and as well as other resources mentioned. I know we didn't get to the questions in the recorded segment. We invite you to stay after the show. For those of you that have questions, Dr. Taylor and Dr. Lovely are going to be able to stay with us, and I will promote you to panelist. If you'd like to stay, I'll tell you more about that. Before you leave, I do want you to know about our next webinar. It's on August 19th. It's always the third Wednesday of the month at 5:30, and it'll be a fun one. It's The Healing Power of the Arts, a Palette of Possibilities, and Jenna Leek is the Director of Art for Recovery program at UCSF. She is going to be facilitating that discussion and experiential exercise with us. So I think that'll be a fun one. I hope to see you there. And so thank you all. For those of you that are leaving us now, I appreciate you joining us, and we hope to see you again in the next event and webinar.
Thanks so much, Naomi.